Hello there, class. This is Dr. Bourgeois, and this is a presentation to continue with the wrist and hand content. We'll be talking about more conditions, following from what you already know, talking about their definitions, the related anatomy, and then we could talk about what possibly will cause these conditions. And it's just some things that you can typically run across in a clinical setting. We'll also try to review some of the conservative management approaches. And also, from some of these conditions and most of these conditions, you're going to also talk about the non-conservative or surgical approaches and what role we will play as therapists within those situations. So the first condition isn't really a condition. It's really talking about a region, and they call it the no man's land. And the reason is that this is a highly sensitive area in the sense that it's delicate, because if there's an injury in this area, you're most likely going to be a surgical candidate. And we'll talk about a couple of reasons why, but this region consists of that distal palmar crease to about the middle phalanx area. So you can see that highlighted area in the picture that depicts the no man's land. And what anatomical structures are in there? So the main thing we're concerned about anatomically, right, is the flexor digitorum profundus and the flexor digitorum superficialis tendons, right? You can see where they'll run through this area, but it's also their related synovial sheaths that surround them, that tube, so to say, that these tendons run through. So why is this considered no man's land? Is if there's an injury here, it's difficult for this area to heal. One is mostly due to the blood supply. So tendons have blood supply, and they can heal. However, they don't have the best blood supply. Then you add a synovial sheath around it, and then you have decreased blood supply, even more decreased blood supply. So the likelihood of an adhesion to occur in this area is high. So managing it conservatively can sometimes be difficult. However, we're going to have to worry about these same consequences post-surgical as well. If there's one area that you don't want to have surgery on or an injury on in general, is within this no man's land, because there's less success rates in there. So think about it. If you were to rupture a tendon in this area, let's say it was cut or some type of trauma, the likelihood of that tendon retracting is highly probable, and if it were retracted, it would be pulled down much lower, because it's an extrinsic muscle. So it would have to be a very difficult procedure for them to go in and restore that tendon to the place it's supposed to be. And then again, once they get it attached and the synovial sheath and everything around it, you could have difficulties restoring that normal glide in that area. Again, that's our job, and that's things you need to be thinking about, and what we'll talk about in classes. What can we do as physical therapists in treating this condition post-op, and treating these patients who've had an injury within this area post-op? And then that will be in according to the stage of condition and where they're at post-surgery, and what choices you'll make when it comes to interventions. So think about that. I want you to reflect upon that, and we'll talk about it in class. What can we do for these patients? Next condition is Colles fracture, okay? And we're just talking about legit fractures here in this instance. And it usually happens with a fall and an outstretched arm, right? You guys have heard that acronym, AFOOSH. And in this one in particular, the wrist is in an extended position when they fall. It's the most common, right? When you fall, most people will extend their wrist to catch themselves in order to brace. And what happens is that there's a fracture, usually a transverse fracture at the distal radius. And you'll see this deformity that most people talk about, and it's commonly called the dinner fork deformity, is because that distal fragment that's broken off in the radius is either shifted posteriorly or dorsally, or has that dorsal angulation, which gives it this, as you can see here. If you place that arm in an anatomical position, it would somewhat look like a dinner fork. So what can we do in this situation? So conservatively, it is somewhat possible to manage this conservatively. It depends on the extent of the fracture. If it's just a minor one and there isn't a whole lot of displacement, it is possible that maybe we wouldn't do this as physical therapists, but it is possible for someone to relocate that manually, brace it, or immobilize it for a period of time in order to try to get it to heal on its own. And then from there, you would need to start the rehab process to restore strength and range of motion and decrease swelling and whatnot. However, most of these cases are surgical cases, and you've got a couple of options there as well. So the most common is the ORIF. You see it in bold here. So what does ORIF stand for? That means open reduction internal fixation. So it's a surgical procedure where they'll go in and actually implant plates, screws, or whatnot, whatever they need in order to get that alignment of that bone to back to where it needs to be, and that the healing process starts. So it has that support inside. They also have what they call an external fixator, is what you see here in the picture, and that's where it's a surgical procedure. They realign things, but the device that's holding it in place is external to the body and could possibly, or should be removed at a later time once healing has taken place. Either or, again, there's a place for physical treatment, physical therapy treatment. As you can see here, I want you guys to reflect. What is it that we will need to do when we get these patients in our clinic? And I'll give you the first one that you maybe be thinking about. So there's most likely going to be a lot of swelling in this area, right? All the remaining edema. We'll need to treat that. How do you treat that? How do you manage that? So the first step, palpation for condition. What do you see in your exam? What would you see or be thinking about, concerned about with your structural inspection? What would you be thinking about or suspect to see with range of motion? Okay. What about neurovascular assessment? What would you possibly see? And how could you address that in a clinic? How could you treat that? Okay, reflect upon that. The next one is basically the reverse of a Colles fracture. So a Smith fracture is where the distal fragment is displaced anteriorly or volarly. And it's not as common because most people don't fall in a wrist flexed position, but that's how this injury can occur. So let's say they weren't quick enough or able to get their wrist in that extended position, which is normally the position that occurs to brace yourself, but they fell with their wrist in that flexed position. And you can see where that could possibly displace that distal radius anteriorly. Now, something to clarify there, these two conditions, Colles and Smith, doesn't just only involve the radius. By definition, it is the radius, but it could be both the radius and the ulnar involved. So here's an example of a Smith fracture there. Again, you can try to conservatively manage this, maybe with a closed reduction, immobilize them for 2 weeks, maybe with something more extensive like a long arm brace. Then you could go into another 2 to 3 weeks of a smaller arm cast, and then at that point you would reassess. Maybe after that period of immobilization, you notice that there's still some malunion. It didn't actually heal the way it's supposed to. Then what step would you take? What would you guys think would happen after that? Yeah, they're probably a surgical candidate. You'll need to take those steps to possibly go in and do that ORIF, or the external fixator, to get the appropriate healing and alignment. So think about what would happen if this healed in this inappropriate position. What conditions could come about? What could this patient struggle with? Okay. De Quervain's, you guys have heard about this, seen this a couple times already, but let's talk about it. It doesn't hurt to review this even more. The anatomy that's involved, okay, is the APL, or the abductor pollicis longus, and the extensor pollicis brevis, okay, EPB. You can see that it runs right here in this first tunnel, right? The first tunnel for these extensors here. The extensor pollicis longus runs dorsally right around the Lister's tubercle, so it's usually not involved in this condition. Now, what is it? Okay, what is the definition? Well, it's an overuse injury. Okay, it's tenosynovitis or tenovaginitis in this area. So yeah, the patient probably had a report of maybe they painted their whole house, or did, played extensive amount of tennis or golf games, or something that would involve a lot of radial deviation, and especially something interesting that would increase thumb extension and thumb abduction. Okay, so anything that would reproduce that movement and create irritation there in a repetitive manner could create this condition. So let's run through the steps. So for this one, we'll talk about them. Okay. So in your examination, what do you think you'll find? How about palpation for condition? Excuse me. So palpation for condition, you're going to see some what? Maybe some warmth, a little edema, swelling. Okay. Maybe even some thickening over those two tendons in that extensor tunnel. So what about active range of motion? Okay, which ranges of motion, which directions would you suspect would reproduce your patient's pain? Yeah, how about starting with the wrist? How about ulnar deviation? Do you think that would stress those two tendons there? Yeah. What about thumb flexion and adduction? Right. That would definitely also reproduce that patient's pain. Now, actively, it may reproduce it if you're going in a direction that would contract those muscles as well, so you'd have to be aware of that. So again, it's irritated. Passive range of motion. Okay, let's start with classical. Where classical wrist, same direction. If you do it passively in ulnar deviation, it's probably going to reproduce the patient's pain. But that doesn't mean that passively in a radial deviation direction wouldn't reproduce it either, because maybe it's compressive on that side. Maybe it's closing down, which could also maybe reproduce some of their symptoms. So again, you got to think about this from what is it going on anatomically and what could actually irritate that tissue. Same goes for the thumb. If you move the thumb in a flexion and adduction direction, you could possibly reproduce that patient's symptoms. All right, how about an MSTT? What findings would you have with an MSTT? Yep, most likely strong and painful, especially for thumb abduction and extension. Now, with a strong and painful MSTT, you can move on to an MLT down the line, and what would you find there? Right, positive, shortened, something that would reproduce pain with the APL and the EPB. Now, what do we know about special tests? A special test is basically a fancy MLT. You guys have heard of the Finkelsteins. These are the steps. You've reviewed this in lab, but I want to go over it again. So what are the steps? First, active thumb flexion. 2, active finger flexion over that thumb, right, so that they can maintain that position. And then you, as the clinician, will passively ulnar deviate that wrist, basically elongate that tissue. That's for step 3. Now, positive is technically pain in any of these steps, but in order for it to be a true Finkelstein, you need to complete all 3 steps. Okay, treatment. We'll go over this mostly in class, but I want you guys to reflect on what would a patient receive if they were treated by a physician and they walked into their clinic with this subject of complaint. How would you manage this as a physical therapist? What would your approach be to managing this condition? And reflect upon that. We'll talk about that in class. Okay, next condition we'll talk about is intrinsic tightness. Okay, what structures are we talking about when we reflect upon intrinsics? Mostly here in this case we're talking about lumbricals and the palmar and dorsal interossei. Okay, and that's what you're testing when you're doing the Bonnell-Littler's test. Okay, you guys remember this as well. So step 1, MCP extension and passive PIP flexion. Okay, if you are unable to flex the PIP to what you think is full range of motion, you need to progress on to step 2. And again, it's probably a good idea to do step 2 if you're not sure what normal range is for that patient anyway. So step 2 is where you would flex the MCP and flex the PIP as well. This is all passive. Okay, then you're going to come up with 2 scenarios from that point. Let's say you're able to flex the PIP even further in step 2. At that point, you should be thinking about intrinsic tightness, right? Either the lumbricals or those 2 interossei are shortened, right? It's taking that length-tension relationship out of play. Okay. Now let's say that PIP does not flex any further. You have the same range of motion at the PIP as you did in step 1. So now you're thinking, okay, there's something related to the joint, right? But there's other things you need to think about. In this next slide, you can see what could potentially create that same finding in step 2. So what the basic principle here is what would create a false positive for Bonnell-Littler's step 2, where the PIP remains the same range of motion. And these are some items that you can think about. There may be a couple more. Hopefully you guys can think of some, and we'll talk about them in class. Okay, the next condition we're talking about, lunate displacement. Now, something I want to highlight to start off with is that I don't want you to think lunate displacement as in lunate dislocation. That's not the case here. It's probably more appropriate to say lunate malalignment, if you will. It's more of a hypermobility. There's a laxity going on there, and it's just not sitting in the perfect condition that the lunate typically is in. And most commonly, again, you'll see here that this displacement or malalignment is usually in that volar direction. And why do you guys think that? Why would it most commonly go in that volar direction? Think about your orthokinematics, right? We normally catch ourselves in a wrist extended position, right? We push and all that good stuff with that wrist extended position. Where does the lunate shift or slide or glide in with that extension of the wrist? Yeah, so it goes anteriorly. So that's most likely where you'll see it go. They're going to struggle with, okay, any type of extended position, especially if they extend and load. And in secondary complications, you can think about the anatomy there. What's sitting right in front of the lunate in that tunnel, right? That anterior tunnel, you have that median nerve running through there, which is something that is easily irritated. So they may have some neurovascular issues going on there that you'll need to check out. And then you'll find some. Let's start with the second highlight on signs there. You'll see that there's going to be decreased passive range of motion. And what would you expect to feel with an in range there, right? With the classic passive extension. Okay, you could, those two bones could articulate there. You get that bony block feel, and it's going to be probably uncomfortable for that patient as well. So the symptom behavior will be pain with that. How about the accessory mobility? You should feel a laxity in that lunate. And what would you suspect the infield would be with that passive accessory? It probably wouldn't be bony in that case because you're not getting to that in range. Likely you're going to see a capsular or a ligamentous infield with that passive movement. All right, so moving on to the next condition, we got Kienbach's disease. And again, this is a disease, so it's a little bit different from the rest. But we're dealing with like an osteochondrosis, you know, that avascular necrosis. But this is specifically talking about a problem with the lunate. Okay, lunate does have blood supply, and so that doesn't necessarily mean why this occurs. It's more of a over-traumatic or a micro-trauma reoccurrence to this area. Okay, so think, for instance, what if you have someone who's been in construction their whole life and they spend a lot of time working the jackhammer, or you have a carpenter of some sort that did, you know, maybe a lot of manual hammering, or they work some type of vibrating equipment where the wrist was an extension and loading and putting pressure on that lunate over and over and over again. You know, maybe it could lead to this type of condition. And you may be thinking, okay, well, heck, what do we do about this? Well, yeah, there are conservative management approaches to try to treat this, which would probably be more of a mobilization. But even before that, you may even be thinking, well, how do I find this? How do I identify that it is indeed osteochondrosis of the lunate? So what clinical findings would you need to identify to come to this conclusion, right? You would see, you know, palpation for tenderness over the lunate, maybe some decreased range of motion, lack of strength, obviously because of pain. But what do you think is the number one thing that would help you confirm, you know, the golden step, if you will, to identify this osteochondrosis in the lunate? And it's toward the end of your steps. What do you think? Yeah, this would have to be an imaging thing. You'd need to get a solid confirmation with an image to determine that necrosis in this area. Again, you can conservatively manage this. You could try and attempt to immobilize it for a period of time, anywhere from 6 to 10 weeks maybe, and then only allowing that patient to get out to do therapy where you're immobilizing some range of motion, kind of bringing in healthy nutrition to try to stimulate that health. Patient should probably sleep in that brace after that point as well. So you're just trying to bring in a nice, healthy, healing environment without creating more and more trauma to the area. Otherwise, it could be just a surgical candidate. You know, they may need to excise the lunate, which wouldn't be the best, but it is possible. Or they may be doing some bone remodeling or something of that sort. Okay, the last one we'll talk about here is the pisiform. And it's not necessarily a condition of itself, but you'll see how the related anatomy around it is related to a few other conditions. And we'll talk about those other conditions here in the next step, or the next wrist and hand overview. So what 6 structures do we need to know about here? They're listed for you. You've got 2 muscles, 2 retinaculums, and 2 ligaments. So the 2 muscles, abductor digiti minimi, that's on the distal part attaching to the pisiform at the most distal end. FCU, which is flexor carpi ulnaris, attaches to the most proximal side of the pisiform. And again, one pulls it up and one pulls it down. Flexor retinaculum is pretty much the obvious one, and something I want to highlight here that may be a little confusing between ortho class and your biomechanics class. The flexor retinaculum is basically synonymous with the transverse carpal ligament, and that's what you're calling it in biomechanics lab when you're dissecting it out in the cadaver. And I want you guys to pay attention to how thick that ligament actually is and what we're dealing with when we're trying to manage conditions such as carpal tunnel. But that retinaculum does attach to the pisiform there. And if you're real savvy in cadaver lab, you can grab that pisiform once it's resected, and you can wiggle that pisiform around and maybe see how you could affect that membrane or that retinaculum. Believe it or not, the extension retinaculum does attach from the posterior side. It's a little bit hard to believe, but indeed there is an attachment there. And then your last two, again, are ligaments. The ulnar collateral ligament attaches, and probably the most significant ligament is that pisiohamate. And we'll talk about that here in a second. But look at that anatomical picture there and tell me what you think is important about that pisiohamate. Okay? What can we do with this pisiform? How can it help us out in the clinic to maybe rule in if it's involved with some of these conditions? For instance, let's take carpal tunnel. Let's say that a medial glide of that retinaculum, or again, the transverse carpal ligament, either one, reproduces the patient's median nerve symptoms, right? Or two, is just simply restricted. So you could think that, hey, maybe this is involved in this median nerve irritation right here through this tunnel. And again, we say medial glide, which means basically in the ulnar direction. Again, we name that in reference to the anatomical man. Okay, accessory motions go in relation to the anatomical man. So you as a clinician could have this finding and suspect that maybe it's related to that nerve compression. So again, you can stretch that out. Again, hypomobility of the pisiform could maybe lead to that tightness of that flexor retinaculum. So mobilizing that, stretching that retinaculum out could indeed maybe decrease that compression there, decrease the threshold of irritation at that nerve, and have a positive outcome for that patient. And then even in other directions, what about, remember how I was mentioning the pisiohamate? Pisiohamate runs from the hook of the hamate to the pisiform. Okay, what is that region right there? We talk about it all the time. Got to palpate it, all that fun stuff. Yes, it's Guyon's canal or Guyon's canal, however you want to pronounce it. Significance, ulnar nerve and ulnar artery run right through that. So the pisiohamate ligament is the roof of that canal. This artery and nerve runs right underneath it. Okay, and right after that is where you'll see the branch of the deep ulnar, superficial, and they do their innervations from that point. And you can see that anything after that would be compromised if there's compression in this area. You as a physical therapist could potentially move that pisiform, inferior and medial direction that could potentially decrease that pressure over time. But we'll talk about a little bit more some of the concepts you might want to think about when you're treating a patient in the review. Just some nice foods for thought. That about concludes it. This is just a nice anatomical picture for us to look at and maybe talk about some of the details down the road. But I appreciate your time, and I look forward to doing the review with you guys in class. Goodbye.